Good morning. In this program, I'm going to explain how capnography should be used during sedation. American Society of Anesthesiologists and Association of Anesthetists of Great Britain and Ireland have introduced capnography to, to monitor the patient during sedation in 2011. Since then, many associations across the world have introduced capnography to monitor the patient's ventilation during sedation. Why was capnography introduced to monitor ventilation during sedation? The first one is it is difficult to predict how an individual will respond to an administered sedative. And we all know as clinicians about this point that every patient responds in a different way for the same amount of sedative drug. Incidence of hypoxia is less if capnography was used to monitor ventilation, according to some of the studies. Capnography, when used in conjunction with pulse oximetry and visual inspection of the chest, detected respiratory depression 17 times more often than without capnography. And this is one of the main reasons why capnography was introduced into clinical practice. And another important aspect of capnography is it forewarns of impending hypoxia by about 5 to 240 seconds, which is roughly 4 minutes, before you can intervene and take corrective measures before the onset of hypoxia. So it gives roughly 4 minutes of time. Capnography triggers an early intervention and therefore decreases the incidence of oxygen desaturation. And this is no-brainer. Administration of supplemental oxygen delays the onset of desaturation following apnea, and therefore relying only on pulse oximetry alone will delay intervention. And this is an important point to remember whenever you give oxygen during sedation, that it may delay the onset of hypoxia despite hypoventilation or apnea. Now, the important aspect of capnography during sedation is what is the baseline value and what is the shape of capnograms before you start sedation. This question I am asked very frequently in my lectures. Although we expect a normal capnogram with a normal value of 35 millimeters or above, it is not always possible to get normal shape or normal value because of a concomitant administration of oxygen or dilution of expired gases by atmospheric air. Therefore, the important concept here is to determine changes in CO2 values or shape from baseline capnograms during sedation. So basically what is it is, you have a baseline capnogram, then you see how these baseline capnograms change upon administration of sedation. A normal baseline value of 35 millimeters of mercury and above is preferable, but not always possible. And I have given the reason why it is not possible. This is one of the capnograms, not completely normal looking, but we accept this as a baseline capnogram. Now, three important components of capnography are important during sedation. What is the respiratory rate? What is the end tidal CO2 values? Whether it increases or decreases. To explain further, There are three things that can happen to end-tidal CO2 during sedation. No CO2, decreased CO2, or increased CO2. If there is no CO2, it is either apnea or total respiratory obstruction, or there is a problem with the sampling of CO2 from the patient. So therefore, immediately you observe the patient to determine what is the cause of no CO2. If CO2 is increased, then it is hypoventilation. If CO2 is decreased, then it could be hypoventilation, partial respiratory obstruction, or hyperventilation. It could be one of these three. So you look at the respiratory rate. If the respiratory rate is increased, then it is hyperventilation. If the respiratory rate is decreased, then it is hypoventilation or partial respiratory obstruction. So to differentiate between these two, you give jaw thrust. And if it is relieved, then it is respiratory obstruction. And if it is not relieved, then it is hypoventilation. This is an example of oversedation. You can see this is the baseline capnogram. And here, this is during sedation. The respiratory rate is decreased here because of sedation. And this should tell us that this patient is sedated and is breathing at a lower respiratory rate, therefore should be cautiously monitored. This is another example where this is the baseline capnogram, and during sedation, the height of the capnogram is decreased. This could be because of hypoventilation, or it could be because of respiratory obstruction, and as I explained in the earlier slide. So this is a patient with sedation, and the end-tidal CO2s are 51. So the height of the capnogram here is increased, and probably it is because of hypoventilation. If there is a total apnea or a flat line on CO2, it immediately summons our attention to determine whether the patient is apneic or there is a sampling issue of expired gases. Now, there are many devices in the market, and the way I sometimes use is, this is the nasal cannula here, and I use the nasal cannula to monitor the end-tidal CO2. And I administer oxygen via an oxygen mask. And I also make a small hole to facilitate the insertion of endoscope by the gastroenterologist during endoscopy. There are commercially available masks using the same principle now, and which can be obtained from the vendors. And this is a very normal looking capnogram during sedation, and you can, and also with the concomitant administration of oxygen. There are a lot of examples of CO2 sampling devices available in the market, such as this, a regular oxygen mask with a sampling port for CO2, or you can sample from one of the prongs of the nasal cannula. This is again another example of concomitant administration of oxygen and CO2 sampling. If you search on the Google the CO2 sampling devices, you will see variety of devices that are commercially available that could suit your practice. So what is the conclusion? The conclusion here is, place the sampling device and obtain the best end-tidal CO2 values and waveforms. Look for changes from baseline values and shape of capnograms. Hypoventilation is suggested by a decreased respiratory rate, increased end-tidal CO2 values, or decreased end-tidal CO2 values depending on the cause. Hyperventilation is indicated by an increase in the respiratory rate. Look for evidence of respiratory obstruction. When you begin to see changes in end-tidal CO2 value or shape, lift the jaw forward, relieves obstruction of the upper airway obstruction, and increases end-tidal CO2. So you can actually pretty much choose an algorithm for successfully using capnography during sedation. These are the various references which you can read, and you can visit my website on capnography and look under Capnosedation for all the details. You can also download a PowerPoint of this presentation. In fact, this is my office door, and it has this, this is the socks which is stuck on my door that says keep calm and capno on. Once you get used to using capnography during sedation, it is very difficult to do a case without capnography. It makes our lives as clinicians very easy during whenever we are administering sedation to the patients. So these are a couple of questions which you can read and see if you understand capnography. The normal end-tidal CO2 value in healthy adults breathing normally with good sampling is 80, 40, 20, 25. We would probably prefer 40 millimeters, but as I said, sometimes you may have to accept a lower value as your baseline value. But in general, about 35 to 40. So B is the answer. During capnography monitoring for sedation, it is important to determine end-tidal CO2 changes from the baseline capnogram. Is the statement is true or false? This is a true statement because you only need to determine, we use capnography to determine changes in either CO2 value or shape of the capnogram from baseline to that during sedation. So the answer is true. If end-tidal CO2 increases during sedation, what does it suggest? Hyperventilation, hypoventilation, respiratory obstruction, low cardiac output. So it is hypoventilation. If end-tidal CO2 value decreases during sedation, what does it suggest? Hyperventilation, respiratory obstruction, hypoventilation, and all of the above. The answer here is all of the above, and I showed you an algorithm of how to use capnography during sedation. Generally, capnography changes like hypoventilation or respiratory obstruction occur before oxygen desaturation. Is this statement true, false, or neither? Capnography changes like hypoventilation, respiratory obstruction occur before oxygen desaturation. The answer is true. Capnography forewarns of impending hypoxia. So the answer here is true.